Thank you very much. Well, let me start by first of all thanking you for being here on what looks like a nice Saturday afternoon. You're taking time away from family, friends, and other activities. And nice Saturday afternoons aren't always easy to find in Columbus, Ohio. It's a privilege to be able to have the opportunity to discuss with you the evolution of desmoid therapeutics. You've heard from the current experts. I am no longer active in the operating room. Two claims of possible distinction. I'll be 76 at the end of December. I I was part of the original founding group of the DTRF. We attended the very first planning meeting, which was in person because in northern New Jersey, because things like virtual meetings didn't exist at that time, and that was more than 30 years ago. And it's amazing how this has grown. I guess one of the other aspects of differentiation, if you will, I have two different forms of cancer. They're both in remission after some very aggressive radiation, chemotherapy, and surgical resection treatments. Very, very fortunate that Dr. Grignol, who you've just heard from, was my partner clinically and in laboratory research and remains very active. Gabe and Dave, they're part of a team. And we'll come back to that concept of why a team is important in managing these diseases. And I think that you'll see how that evolved from solitary practitioners with their own specialization, seeing patients not at the same time, not in teams, but step by step, and how that was improved on for the patients, particularly in terms of local control. Let's start with where the term even comes from. It's from Mueller, who was a pathologist in Germany in the early 1800s. The word desmoid is derived from the Greek word desmos, meaning band-like. And if you've had the opportunity to see how these tumors set up bands of tissue, you can understand that was an apt descriptor. And he published this in a book, Über den feinen Bau und die Formen der krankenhaften Geschichte, which is translated about the fine structure and types of pathological tumors. So desmoid was just kind of grouped in there and as one of the pathologic band-like tumors. And it remained as such basically all the way through and after World War II. General considerations, very rare tumor, about somewhere close to 1,000 in the entire United States, three anatomic varieties, and they can locally recur, but no distant metastasis potential. The cell of origin is not specifically known, although that comment is rapidly being revised as we focus more and more on the underlying genetic component driving this tumor inception and recurrence. And so I'm confident that the underlying biology will finally be teased out and that we will have even more effective targeted therapies to enable us to move forward with minimal toxicities for the individual patient. Just some quick examples. Val has gone over this material, but you can see the challenge. This patient with an intra-abdominal desmoid growing out of the root of the mesentery. There's no way to get underneath that tumor to get control of the blood vessels. And so you heretofore would just make a decision that it was unresectable because of the lack of vascular control intraoperatively, and or the amount of tumor that would impinge on the normal bowel, necessitating large components of intestine to be removed. People, as Val alluded to, can live with total resection, and sometimes, very rare, that becomes necessary, but they live on intravenous hyperalimentation for the rest of their lives, are in and out of the hospital, and it's very, very challenging for patients, families, and caregivers as well. Abdominal wall desmoid tumors, a patient that I operated on 13 times before she finally, or he, or the tumor, whatever is the appropriate pronoun in this era of shifting pronouns, I guess 13 operations, 13 recurrences, call it they, finally gave up the ghost. But you can see a picture of this tumor on the left eroding right through the iliac crest of this patient. So that's a real example of how locally aggressive these pretend cancers can be. We don't think of it in terms of it being anything less than meriting the attention that we would give to any other type of abnormal quasi-malignant or malignant growth. And then extra abdominal desmoid tumors seen here, most easily closed when I did this operation now almost 20 years ago with a skin graft. We didn't have the type of microvascular reconstructions or understanding of the vascular supply of underlying musculocutaneous bundles such that something could have been rotated into place there relatively easily now by a reconstructive surgeon. And they wouldn't be anywhere near as scarred with all of the cosmetic and functional defects that entails. Differential diagnosis, a long string of possible other entities that this can be confused with, most of which have different therapeutic approaches, which is why biopsy becomes very important. The first bullet points to scar, and that is what is frequently the source of confusion, but we do have ways of differentiating them. The desmoid, as an abnormal collection of cells, produces certain abnormal amounts of proteins. And so beta-catenin is the most commonly overproduced protein in the desmoid. And unlike scar tissue, which is shown in the upper left, in the desmoid, the beta-catenin is located in the nucleus of cells. And so the arrows are pointing to nuclei containing the desmoid precursor cells. And you don't see any arrows pointing to the nuclei in the scar because they don't contain the desmoid. And this is a standard immunohistochemical test that is available in any pathology lab, certainly in the United States, Europe, Far East Asia, and even in the third world, so that there's no reason why a patient shouldn't get an accurate and specific diagnosis of desmoid. And yet Dave is shaking his head because we see all the time patients who have had various interventions without benefit of knowledge of what type of a problem the patient is really confronting. So diagnostic strategies. A key point is imaging before the biopsy using the very best modality. Quick and sometimes dirty ultrasound, you can at least see that there is an abnormality as is shown in the upper left panel, but it doesn't really give you much information about where the desmoid sits vis-a-vis the other anatomy in the tumor location. You get more information from the CAT scan And the best of all is the MRI scan, which you can see in the right lower quadrant. And the arrow points to the sort of kidney bean-shaped desmoid tumor. But even non-radiologists like ourselves can look at where it's located and see that the anatomic location to the other structures is the best with MRI. And the specificity factors when patients have had both MRI and CT scans performed runs in favor of the MRI by a specificity factor of about 25%. So that's why the MRI is the preferred study if it can be made available. How these tumors are biopsied is very, very important because it can radically change the outcome for patients if it's done inappropriately. The cartoon shows a desmoid in the just below the knee and the lower leg. One approach is a needle biopsy, frequently with image guidance like ultrasound. Other approach would be, if it's small enough, simply remove the tumor as an excisional biopsy, with the added caveat that it's difficult to assess desmoid margins using frozen section. Not impossible, but if you're going to do a simple excision of the tumor, simple is probably the wrong word. There's never a simple excision. Always something to think about. But the point ultimately being that removing it implies that there's a cup of normal tissue, so that you aren't totally relying on frozen section analysis to decide if you've cleared the tumor. And if it's a larger tumor, incisional biopsy, deliberately leaving some tumor behind, which would then subsequently be removed. Stay there. In the definitive operation. Now, why did that do that? Let's see if I can make that go away. There we go. How about that? I'm computer illiterate. My son taught me how to email when he was 6 years old, so I stumbled through some of these electronics. And as I just mentioned, and as others have alluded to, how the biopsy is performed is critical. The first teaching point, if you will, is that the biopsy should be oriented along the long axis of an extremity. If it is an extremity desmoid, and that's one of the most common, if not the most common location. And so the cartoon shows the way that this would be approached. The lower left-hand corner implies that excellent hemostasis, control of any bleeding has taken place at the time of the biopsy, so that you don't have bleeding potentially carrying desmoid cells up and down tissue planes within that long axis. Now, I'd like to give you a little patient vignette to show you how that makes a big difference. In the left-hand plane, you can see dotted around a tumor, a little bit, if you use your imagination, bulging out from the upper shoulder girdle musculature. The oval is enclosing a transverse scar that was not up and down the parallel to the long axis. The optimal biopsy would have been the heavy red scar cutting there. And the reason for that is, if you look at how we had to close the incision, we had to encompass the entire previous scar, which was misoriented, as well as rim of normal tissue. And so this required a double Z-plasty. And you can see on one of the tips, there's a little bit of necrosis. We got away with it, but frequently that's not the case. And that whole incision was potentially at risk. The little dots that you can see around the perimeter a technique that is sometimes used for topical radiation called brachytherapy, with implantation of catheters that are then afterloaded with radioactive low-dose wires. And we had to encompass the entire surgical field, which extends it another 40%. So what would have been a very simple up and down straight wound closure becomes a major undertaking just to establish the diagnosis. There are principles that Val, I think, has also touched on, which so we won't go into much detail, but these are the thought processes, the decisionings that a surgeon needs to apply. Critical that someone understand the natural history of local recurrence and not metastatic disease, getting the imaging of the tumor area before the biopsy so it's not a disturbed biopsy site that's potentially contaminated with hematoma if there was a problem with controlling bleeding. The biopsy needs to be planned with the ultimate resection in mind so as to minimize loss of uninvolved normal tissue, and that necessitates planning the reconstruction in advance. Oh, there we go again. And that is a critical step in the process. It shouldn't happen at the end of the chain. This would be part of the group decision about how best to take care of it, because our reconstructive surgeons are capable of marvelous, truly miracles in many situations. But if they don't have the opportunity to meet the patients, discuss the options, secure their approval, it's not going to be as good a working relationship as possible. During surgery itself, we make whatever incision we need to, consonant with getting exposure, particularly for the critical neurovascular structures so that they aren't inadvertently divided, controlling the critical anatomy, delineating the margins, and block resection, meaning the entire tumor with cuff of normal tissue, and then frozen sections. But these are, as I mentioned, difficult and unreliable in desmoid tumor. Just a little sidebar word about frozen section. I wonder if anyone in the room knows who was the first practitioner to use frozen sections. Rudolf Virchow in 1869, and we're still using the same technology. Just keep that in mind. We think about the surgery as there are differences between something is resectable and something is simply removable. They are not the same quality, although they may ultimately end up, hopefully, in the same good outcome. Removable means that the patient and their tumor can be separated. Resectable means that it is removable, but in addition to that, there are other factors to consider. The anatomic constraints, tumor biology constraints, surgical intent constraints, and quality of life constraints. And these are all issues that need to be discussed in planning processes prior to subjecting the patient to an operation. So everyone, including patient and family, are in agreement about what needs to happen. A couple of thoughts about some of the treatment approaches. Radiotherapy. When I was in training, which a long time ago in the early 1980s, was just about the time that radiation was being considered for desmoid tumor. Up to that point, the treatment for a desmoid tumor, particularly of the extremity, was amputation one joint above where the tumor was located. That's pretty drastic. And Herman Suit, who was at the time a radiation oncologist at MD Anderson, where I trained, subsequently became chief of radiation therapy at Mass General, said, well, gee, if you're just ablating the tumor by amputating, let us have a shot at trying to radiate it and control. And it turns out that not only was that effective, but in some situations where the surgery would be too morbid, it is considered as primary therapy. This is an earlier series from Anderson in which that approach was first published. There's many controversies about the use of radiotherapy in desmoids before or after surgery, as standalone, total dose. Is there a role for sensitizers, including as we are learning more and more about the underlying biology, molecular biology of the tumor? Use with macroscopic residual unresectable desmoid, a critical nerve or blood vessel or inaccessible tissue to get a margin might be a situation where radiation would be considered. And should it be used in microscopically positive versus negative margins? The large series suggests that microscopic positivity results in the same approximate rate of local control as negative margins. So that also has to enter into the decision about how aggressive you want to pursue a tumor like this, particularly in the face of critical unresectable anatomy. When systemic therapies were initially considered, it started with doxorubicin-based therapies. A paper that Shreya Patel published when we worked with him at Anderson, showing a patient who received doxorubicin-based chemotherapy, and the stuff works, but in a very unspecified manner. Hopefully people don't have much experience with it anymore because it's falling by the wayside. But in my own soft tissue tumor practice, I've had 3 patients who have received doxorubicin with good result for their tumor control, who ultimately came to cardiac transplant because it causes fibrosis of the myofibrils. So you have to follow the ejection fraction very carefully to make sure that that doesn't happen. Imatinib, one of the first targeted therapies. This was demonstrated in the early 21st century. And this series of picture from of a patient from the JCO from that time shows the shrinkage of the tumor in the face of imatinib therapy and concomitant much less toxicity than the non-targeted doxorubicin-based therapies of that era. Sorafenib and now other even more specifically targeted therapeutics, as several of the speakers have alluded to, are now the sine qua non where therapy starts. And last, but certainly not least, watchful waiting. A patient over the course of a 3-year period of time, not resected, simply watched. One of Alessandro Granchi's patients that he's kindly lent me the slides. And you can see how that just responds to watchful waiting. And at least 20 to 30% of patients in large series will show some shrinkage, sometimes enough to get away with avoiding other more ablative procedures. Multidisciplinary assessment at the outset is critical. Input, discussion, decisioning, including the patient and their family. So we, again, as a center, we see many, many patients who there was something there, I took it out, oops, it's a desmoid, and we've destroyed the possibility that the patient could get other very meaningful therapies instead. And so I'll close with a paper that my late wife and I wrote in 2007. And we were thinking about this whole issue about how to optimize the treatment of desmoids. And as we wrote in the conclusion, increased neoadjuvant treatments may be associated with improved desmoid patient outcomes. These trends should be supported, particularly if personalized molecular-based therapies are to be rapidly and effectively deployed for the benefit of those afflicted by this rare and potentially debilitating disease. The next steps are not certain. Active research is going on, not so much in our laboratory anymore, but we've donated tissues and cells throughout the world, literally, and others are carrying the banner forward. And so as we learn more in the lab, the ability to use molecular therapeutics is rapidly coming to the forefront. Others on the panel can speak much more effectively to that than I am. I'm a dinosaur in that regard, but the cartoon shows Gabe or David directly injecting the patient's DNA with some anti-desmoid therapy. It'll come in your lifetime. Thank you for your attention.